Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here on the Lionhearted podcast once again. And I'm going to get right to the meat and potatoes this time, because last podcast I spent building it all up to talking about the importance of you managing those patients that you present comprehensive treatment planning to that don't accept that work. And what do you do with them at that point? And, you know, I'm an advocate of you drawing a line but not kicking out everyone. You know, I'm totally, to be quite honest with you, I have a big patient base, and I'm totally comfortable with patients coming to me every 6 months that have teeth that really need to be crowned but aren't decayed, or it's very incipient decay. And I've recommended proper treatment, but they've declined. I'm talking about patients that I would love to see replace teeth, but they're not ready for that yet. I'm talking about patients that have head-like crowns in their mouth or unesthetic dentistry in the front of the mouth that aren't ready to replace that. So you never know when those patients are going to come around. Or maybe, now I am not talking about things I'm going to get to in a minute by allowing periodontal disease to become an advanced stage when it's incipient. That's what I mean by drawing a line in the sand. And I think a lot of my colleagues, especially some of my younger colleagues, would need help in this regard. But back to my last podcast, I was re-presenting to you just about everything I do in a very summary fashion about getting case acceptance at a very high level. And I do, but I certainly don't get patients to buy into the premier level of what I would do. I mean, you know, that just hasn't happened in my career because I don't have dentists flying in for their work from Brazil to my office, or for that matter, other patients where money is just no object. It is an object most of the time. It is an issue, I'm trying to say, most of the time. So how do we deal with that? And where do we draw the line? So going back a couple steps first, I want you to know this. I say a lot of things in that opening 30 to 40 minutes that I'm with these patients. And I've reminded you more than enough times that more often than not, sitting in the chair next to them is their significant other. And why would I do that? How can you not do that? In 2019, if you're doing a comprehensive exam and looking at everything from their periodontal health to aesthetics to missing teeth to their muscle and joints to their occlusion, it's very unusual to have a patient not have significant need in one of those arenas. Now, it doesn't mean they can't live if they don't do that. Okay? Their life can go on quite nicely, and I'm aware of that. And so what I will say very often in the beginning sometime, and I just say it because it's natural to me, and I guess you'll have to practice this if it's not natural to you. I often say just what I believe in, and I'll say, listen, I want to tell you guys something. That's how I talk. I'll say, I know we don't know each other that well. And I really want to give you the most conservative treatment plan I can, meaning the least invasive, the least costly, the least number of times you have to come here. But I'm going to tell you the truth on what I think you should do as if it was me in the chair. That's how I talk. Now, say I have a patient that comes to me, and I know lots of you have these kind of patients lately. In the last, I would say, maybe 5 to 10 years with the advent of chain offices or corporate offices. And I know not all corporations are bad, but in general, I think some are better than others. And I've had more patients than ever come into my office and ask for a second opinion because they have been going to another dentist for their whole careers, and they went to a new dentist who might have bought the old one, and they were told they had 9 cavities. And they want my opinion. And before I look at that patient, this is what I say. Say, I want to tell you something before I even look in your mouth. If I think you have 12 cavities, I'm going to tell you you have 12 cavities. If you have 9, I'll tell you have 9. If I think you have 5, I'll tell you have 5. I'm going to tell you my absolute truth. I'm not going to tell you what you want to hear to make you like me more. Because I want you to like me, but I want you to respect me for my thoroughness as your dentist, because that should be the first reason you come to me. And I've yet to have anybody interrupt me early in this kind of talk, but I think it's good to say things like that and say that, that's why I'm an advocate of treating problems early, I'll tell a patient. Now, I want to back up and tell you why I'm talking. Say you have a 50-some-year-old patient in your chair, and you know that he went to another dentist. By the way, that other dentist could be the dentist you bought the practice from. And so you got to, let me address that real quick for you. Those of you that bought a practice, you guys have to walk on eggshells for 2 years to gain trust. And I don't think that's a big deal to ask you to do. Unless that patient comes to you with a specific issue that pushed them over the edge. Maybe they broke off a front crown. Or maybe they broke a back tooth and needs a crown. And there are a lot of teeth like that in this patient's mouth. Listen, all you can do is be honest, earnest, and support that with your body language, which right now I'm looking you dead in the eye, with a soft voice that's impassioned about this. That's what counts to me. If I tell the truth, like I'm talking to you right now, and the patient doesn't accept it, then the patient doesn't accept it. And also, I won't hesitate for a New York second to talk a patient out of work and hope someday it comes back to me. I had a patient, get this, that came to me a week ago for an aesthetic consult, and I had treated his boss, his 2 bosses. I had restored a full arch rehab, upper and lower. I mean, I did, in fact, their whole family. And this gentleman was in his 50s and worked for them. But when I looked at him, he had very minor chipping. His teeth did not have a terrific color, and he really probably was a very good candidate for bleaching. And I talked him out of it. And I swear to you, like, did you ever look at a patient and say, why would you want me to veneer your teeth in your head? And this patient was gung-ho. So let me get to a very, very critical principle of success. And that principle is this. You, on your worst day of your worst week of your worst year, if it's next year, God, I hope it's not. But if it is, never once, and I know this is obvious, but just maybe it helps one of you for me to speak this way. Never once can you cross that line on looking for work or, I don't even know how to say it to you. You always, 100% of the time, have to be honest about what you think the patient should do, even if it means you don't do the business. You could say the same thing. A very good analogy is the patient with an atrophic mandible that had a denture made 25 years ago. And they might have gone to a lesser expensive outlet out there in dentistry right now that made him a denture that doesn't have the same retention or comfort that the one that was made 30 years ago. don't you go relining that denture. Don't you believe that your lower new denture is going to be significantly better. I would tell the patient the truth. And I'm not saying you're not telling them the truth. It's just easy for you to drink the Kool-Aid because I've had this happen where the patient came back to me sheepishly with their tail between their legs because they didn't come to me for the second denture because they know I'm not a low cost dentist. I am on the high side. And there's good reason for that. I don't know how you can do excellent work and use the best supplies and higher end labs and keep staff for 20 plus years like I have. If there's a way to do that inexpensively, let me know, because I don't know how to do that. But there's also a market for it. Even in 2019, like there was in 1980 when I started. That would be 39 years. So I have to pause for a second and recognize that even I think it's a little bit ironic as I'm sitting here telling you how liberating it is and refreshing it is to me to talk a patient out of work. I've given you a couple examples of that just now. And yet the intent of these podcasts are to help my colleagues achieve the highest level of productivity and success as possible. Because that is a part of it. We couldn't spend enough time on this particular subject because the issue is this. I think the first takeaway here is that you have to say to yourself, first of all, you got to look yourself in the mirror and say, what am I doing during my process of the new patient experience? What am I doing from the time they call? What am I doing when they get to the office? And really, when I'm in the operatory, what's going down? Am I too timid to talk to this patient about their entire mouth? Because I know that's not why they came in. Am I not confident of my treatment planning skills? Then if that's the case, you need to write to me, first of all, Dr. Rasner at AOL.com, and have me recommend to you treatment planning courses. I can tell you off the top of my head that the Spear Institute in Arizona has a course on several of those subjects. The worn dentition, the facially generated treatment plan. By the way, they don't even know that I'm recommending. If they do know that I'm recommending you to them, nobody's let me know that. And so I'm doing that, of course, without an agenda, or I shouldn't be giving you any information. So are you doing that? Are you confident in that? I mean, maybe you need to sit in front of your computer and practice, because it is the monumental moment of every one of your days that sets the table for what you're going to do next week and the week after. Not to mention resulting in cash flow that makes the whole operation work. So yeah, turning patients down for their work sometimes is the outcome. I mean, listen, I had a patient just recently. So I don't like doing this on the podcast because I don't want to confuse you, but maybe you'll get this one in your head, because I get this patient a lot. So I want you to picture in your mind, this patient comes in just recently, and they have in place number 3 and 4. 5 is missing. They don't have any, number 1 or 2. 3 has a history of root canal, no crown, very large resto. And they have 3 and 4, no number 5, 6, 7, and 8. Heavy fillings, but not too bad. Great bone on all the teeth. The reason they're there is number 9 was a post-core crown that is on the bracket table. Okay, I'm repeating on purpose because I know some of you are, not an area where you can write something down right now. So 3 and 4 is there. 5 is not. 6, 7, and 8. 9's broken. 10 is missing. And 11 is present. And nothing else. And they have a partial denture that doesn't fit well anymore. On the lower arch, pretty much 10 teeth left. 20 through 29. Okay? First bicuspid to second bicuspid to second bicuspid on the mandible. And I don't know why that is a very common patient that comes into me. Missing many teeth. Some occlusal trauma to the... I mean, this would be easy for me if they had perio of any sort. And the reason I'm telling you this story is I have been in a slump lately, as I've mentioned on these podcasts. And this patient comes in, and they were delightful. The husband and the wife were there. They were nice. They were highly recommended to me by another patient. Can you picture this? This is good stuff. Asked if we had credit accounts, patient financing. Asked us that. Okay, so I go in and do the thing you've heard me tell you about for many podcasts. And when it gets to the treatment, my treatment was going to be full coverage crowns, milled to receive a partial on number 3 and 4. Nothing on 6, 7, and 8. Nothing. Just maybe minor restorations. 9, as I told you, was broken. That was going to be extracted. 10 was already missing. 11 was going to get a crown, and there would be 2 implants to the posterior of number 11 with locator attachments. I hope this is not confusing too many of you. Here's the takeaway here. I didn't even treat the lower, not even with the lower valplast or very elementary type of partial denture. Nothing. Why did I do that? Well, they had a history of failure with a lower partial, which I find very common on patients. And I did say, let's see how you do with this treatment. And as we move forward, I will talk to you about different possibilities of lower posterior replacement. I should also mention that in my coach's notes, my coach is Michelle, who's interviewed this patient in the office and interviewed the patient over the phone. She said that money was an issue, that they were on a fixed income. So naturally, these are all things affecting me. And I'm giving a really nice presentation. And they wanted it. They loved the idea. The monthly bill was something they could handle. Because it's not just whether they can finance it, it's can they really handle, do they get approved for finance it, I mean. Can they really handle the monthly bill attached to the finance amount? Well, they got declined by everyone. 3 different companies. Both of them did. I mean, they're in my office for an hour and a half. I'm not in there anymore. I'm in another room after my case recommendations. And they even got a sponsor, which is very common. If you don't know what a sponsor is, write to me and ask me, how do I get sponsors for my patients who get declined for financing? It's very common in our part of the country. I told you, I'm in a very economically challenged area, and it's not a crazy story to have a patient call up a friend or relative. In fact, it was the patient that recommended this patient to me. It wasn't even a relative. I guess they were close enough, but the person that was going to be the sponsor had a limit of around $6,000. And yes, could I have figured out, I want you to hear me carefully, could I have figured out something that would work for me in that range of fees? How about a valplast partial, just to replace the maxillary teeth for now, not the kind I recommended. This is important because I talk to you in these podcasts lately about drawing your line in the sand. And this is a patient who had a failed partial in their hand. They have a failed number 9 post-core crown. I don't know how old it was, so I'm not going to make things up. And I could have made the number work for some type of dentistry. You understand what I'm saying to you? But I really didn't think it was the right treatment plan for them. And had they said to me, can you give me anything to get me by? I guess I could have had them sign their life away, understanding this is not what I recommended. The danger in you doing that is that your practice becomes a practice of compromised treatment plans. And here's the biggest problem with that. I actually think these particular folks that I'm referring to in this story right now were honorable and would be good down the road. But a lot of patients, I'm telling you, get selective amnesia. And I even have a tape recorder that I purchased for new patient interviews. I mean, for case presentations. I've never used it. I think it's a good idea. Where I wanted it on tape, what they said and what I said. Because I've had it happen to me many, many times. I have a nice form now that you can, I wanted to also point one more thing out. I'm sorry to sidetrack you. Next to me, every time I walk into a room to do a case presentation, are 3 boxes that have every kind of dentistry that I do. From a denture to the multitude of partial dentures I do. And I mean on models too. So a Valplast partial or Flexite, whatever you guys call it. A conventional partial with cast clasp. A partial with wrought wire. A precision attachment partial where crowns have been made. And of course, all the different types of implant retained prostheses I have as well. And I now have them visually hold it and sign. And it's done in a very patient friendly way that this is happening. I don't want you think I'm trying to intimidate them. Really what I'm trying to do is protect myself. Because I have a patient right now and he signed his life away that says he didn't think it was a partial. He's been in treatment for almost a year. So I just started these forms. Here's what these forms do. They state what they're getting, the advantages of what they're getting, and that may include costs, by the way. The disadvantages of the prostheses they're getting. It's a lot to remember, but I got to tell you, if you're going to do something I just alluded to, in other words, I mean, I do. Even as I'm telling you right now, I feel a little bit bad about the outcome because the outcome was nothing. No decision was rendered. We didn't proceed with any type of treatment. And it's very easy for you to develop a practice that is either an emergency practice where you treat the emergency of that patient for the day they called you and came in, hoping that they'll come back to you, and sometimes they will. Most of the time they won't. I'm quite positive of that. Or it's equally easy for you to develop a dental practice that is just a litany of compromised treatment plans. I mean, there's no way on earth that a regular conventional partial in the patient's mouth I just described is going to endure long-term for them. And that's an important point I'm making because 3 and 4 years goes by real quick in my life and probably yours too. And in their life, they're going to get 3 years, their reaction is going to be, are you kidding me? This only lasted 3 to 4 years? And how can you really delineate, even in your consent, how exactly long the treatment plan that you're prescribing for them will indeed work? So these are pretty powerful issues. So I think your takeaway today from these last 2 podcasts is I'm asking you to develop, I'm encouraging you to develop a very big patient base. And it's clearly not your way or the highway, not with my model of blueprint I'm trying to impart to you. But there are lines in the sand to be drawn, and they would include, to me, I would never compromise on the perio that I recommend for them. You know, if it's quadrant scaling and root planing and every 3 to 4 months, then that's what it is. If they don't come in, they've signed something that knows I recommended that they know I've recommended that. I certainly would not treat part of their mouth and ignore periapical pathology or large caries that look like they've encroached upon the nerve that could result in an emergency to that patient. I wouldn't do that. I would not engineer any implant treatment plan. Meaning, if they could afford 2 lower implants, in my world, it's a minimum of 3 mandibular implants. And a compromise that I could share with you would be locators versus on a removable implant prostheses. A compromise I would accept that I'm a little more strict about today would be a locator-based partial versus a bar-retained partial implant-retained denture. So I think it's important that you take the time outside of your office, not when you're on the spot, and really, like, you should do these things. And you should take weekends, take a couple hours on your weekend, and think about, okay, what is my new patient process going to be? What is my process when I walk in the room? What is my lines I'm going to draw in this sand? What will I bend but I won't break on? And when can I sequence treatment? I would encourage you. I mean, listen, if you're open up vertical dimension, unless you hold part of the vertical with composite dentistry, which I've done. So, for example, I've crowned 2 through 11. That's probably as far as I would go. I've crossed the arch. And 12 through 14 or 15, I've held that vertical that I opened back up with composites. I mean, that would be 4 more crowns. It's a lot more money. So 12, 13, 14, yeah. So, yeah, I mean, there are things you can compromise on, but there are things that you must not do that for, or it'll come back to bite you. Again, practice. I mean, it is equally important, besides the CE that I encourage you to take to get certain skill sets at a very high level. It's equally important that you practice what I am talking about, unless you're an absolute natural. Anyway, this is Dr. Steve Rasner. This is the Lionhearted. You can reach me at Dr. Rasner at AOL. Oh, by the way, in case I haven't said it in a while, those of you that are interested in surgical skills, I do teach in my office in southern New Jersey. You can come to me without a license in my state. You need a license in your state and an active malpractice policy. And you can practice on live patients, atraumatic extractions, site development, which is bone grafting, all kinds of skills, soft tissue skills, free gingival grafts, as well as, of course, implant training and services. So I hope this has been helpful to some of you. Stay tuned next week to the Lionhearted with your host, me, Dr. Steve Rasner. Thanks.